I'm very pleased to introduce Carolyn Canfield, who's an independent citizen patient and also an adjunct faculty member at the University of British Columbia. Does a lot of important work in patient safety, patient engagement, both in health professional education as well as in a number of other areas in the healthcare system. So Carolyn's going to explain a little bit more about her work and her connection to health professional education, and I will let her give those details.
Thank you so much, Meredith. It's lovely to be here at McMaster, and I bring greetings from the Center for Health Education Scholarship at UBC, which is Merit's equivalent. Thanks very much for tuning in online as well, and welcome to those people who are going to watch the recording of this. So as Meredith mentioned, I have a lot of different hats, a lot of different roles, and these are some of them. Being an adjunct professor is pretty interesting because I never went to graduate school. I was last in a classroom in, I think, 1971. But through my efforts over the last 12 years, I kept asking questions and kept pushing doors open as a patient. And I call myself a citizen patient because I see the world of healthcare through the eyes of a patient from that perspective. But the work I do is as a citizen because I actually want to live in a society that has great care for everyone. I've had the blessing of very good health, but I know that not everyone does. And for me, it's a matter of equity and social justice, and that's why I do what I do with a passion. So these are some of the different roles that I've taken as an advisor, speaker. I work on research projects, including with McMaster people like Meredith, and I've been a mentor to many other patient volunteers. In 2014, I was awarded Canada's first Patient Safety Champion Award, which opened doors for me. I can't say that I'm that outstanding, but it was a real honor to receive the recognition. And I teach patient safety to medical students and to nursing students at the University of British Columbia. So that's just a quick overview, and I'm happy to answer any questions. So I don't have any financial disclosures because I'm not paid. I do accept honoraria from various people who bring me in McMaster a month on that. Instead, I'm here for expenses, which is the usual thing. But I have given talks on now 5 continents to all kinds of people who are interested in the second victim, patient safety issues, patient partnership and research, other areas. So I could stop right now and say, okay, what's going on at in British Columbia, University of British Columbia with patient engagement in health professional education, and just sort of, here's the website or the web link. Might read the report. I can tell you a little bit about the last year and a half. Its date is April 2018. But I'm going to do more. I'm actually going to give you some value for your attendance. And that's due to these 3 people. Angela Toll, Bill Godolphin, and Kathy Klein have really formed the foundation of everything that I'm going to present. There's some exceptions of things I've done outside of that, but they certainly are the inspiration for my involvement in health professional education. They have led the Patient and Community Partnership for Education, which is an interprofessional part of UBC Health, and they're brilliant, passionate. They don't know when the end of the workday arrives. They dedicate themselves to this work, and I just want to pay tribute to them. So, what are the big takeaways? If you have to leave early, here are the big ideas. I'm going to start out with a retrospective on health professional education with a patient. So how did the patient get involved in health professional education? A historical perspective. The middle of my talk, I want to just review my view, a patient view of changing models of care. That is, what do we have to prepare our health professionals for in the future? Because things are changing rapidly with different patient roles and social expectations. And then finally, I want to give you some examples of what's going on at the University of British Columbia, some examples of work that Angela and her group have been involved in, and some things I'm involved in. But the bottom line for me is that healthcare is a collaboration. It's not a service, that it's based on relationships of trust, so that if you want to improve healthcare through better teaching, through better professional service, through better relations, it really is about improving the ability to foster great relationships of trust. So let's start at the beginning. Well, in antiquity, illness and well-being was really thought to come from outside of the human body, forces other than the person. And it was the Greek physician and teacher Hippocrates on the right here, who at about 460 BC postulated that anatomy was the foundation of medicine, and he believed you could learn all you needed to learn from sort of the outside, looking at bones and looking at wounds. And in those days, human dissection was not allowed. It was forbidden, and certainly not encouraged until the late Middle Ages. So the patient really didn't have a role. The patient wasn't active in learning about medicine. And you have to fast forward another 500 years or so until AD about 130 to 200, and that's when Galen was around. And Galen was another Greek. This was during the Roman era, which didn't approve of dissection, examining corpses. But Galen collected a huge number of texts, and Arabic was the scientific language then, just as English is now. And that concatenation of medical treatises was really the reference point for about 1,000 years. Galen was the holder of that knowledge, and he had some anatomical descriptions, but they were often wrong, and sometimes they depended on horses for an understanding of anatomy, on other animals, not on humans. So we fast forward into the Middle Ages, and really there was only gradual acceptance of dissection coming into the Middle Ages, and Holy Roman Emperor Frederick II in 1213 decreed that once every 5 years that a cadaver should be dissected for anatomical studies. So that's not a lot of examination for people who are learning medicine, but he also required that anatomy was required for practicing medicine or surgery. So attendance at those dissections was required for the people who were under his rule. In 1315 was the first public dissection of a human body for medical teaching, and that was carried out at the University of Bologna by Mondino di Luzzi, who was the author of one of the earliest anatomy books. He didn't have any illustrations in his anatomy book, but he did talk about it. It was only 44 pages long, and it became the most popular text for medical students for another 2 centuries. So this is the end of the Middle Ages, gradually into the Renaissance, and just at the cusp of the Renaissance is this illustration. And here, obviously it's a cadaver dissection. I'm not sure I like the puppy dog down below the dissection table, but you can see these are students who are learning from a master, and from this time on, really, anatomy became the central paradigm for medical education, and that remains true today. By the 16th, 17th century, that was the standard. So, in only a very few years after this illustration is this picture. So the Renaissance created this incredibly lifelike illustration. The revolution in science, the revolution in art, architecture, so many different areas. So, I mean, what a remarkable contrast. And this is Rembrandt's famous painting, The Anatomy Lesson of Dr. Nicholas Tulp. And in this illustration, there's no different subject than the previous illustration. This is the patient role in dissection. In this case, looks like a forearm and a hand. And so time marches on, and the patient awakes. So this illustration reminds me how everything changes once that patient awakes and is now alive for learning. And I want to read a short quote from the wonderful general practitioner, Dr. Iona Heath, in the UK. Doctors and other healthcare professionals are not biomedical scientists. They have a different responsibility, which is to attempt to relieve human distress and suffering, and to this end, to apply general scientific discoveries to a series of unique individuals. So, we have then Dr. William Osler, who we know in Canada as kind of a godlike figure. These pictures were taken at Johns Hopkins Hospital in the 1890s, and he created the first residency program. So now we're learning from live patients. And of course, Osler's writing lives today in how important that residency period is in understanding every patient is different, and that you have to meet and greet and touch the patient. I noticed today when I was preparing the slides that his knee is on the bed here, and then one of the other pictures, he's got his heel resting up on the chair. I mean, I know the patient doesn't look too healthy, but I really wonder if that kind of behavior would be acceptable today. In any case, one thing that he wrote in 1901, which absolutely applies today and is quite inspiring in requiring his students to learn from their individual patients by seeing and listening. He writes, "To study the phenomenon of disease without books is to sail an uncharted sea, while to study books without patients is not to go to sea at all." And I like that quote especially because it captures the uncertainty and the partnership, the collaboration that's applied to practicing medicine. So now we're coming a little bit closer to the present day, and there, finally, in the classroom, are some patients. I mean, I don't know when this picture was taken, but I've looked carefully at all those screens, and there's a different image on every screen. I'm not sure how much people in a gallery where we're standing are really paying a lot of attention to what's going on in the classroom. But this is pretty static, and at least it's bringing the lived experience of the talking patient and the patient experiencing probably a chronic condition into the classroom as presenters. And I think we're also all familiar with the standardized patient. And this may be a bit of a cheap shot. This is a UBC image, but I don't think the acting abilities would win an Oscar. And the standardized patient has become a set piece of medical education, and absolutely still is. Another role we have is the clinical teaching encounter. And this embarrasses me, this picture. This is at UBC, it's not very long ago. Here's this kid on the right who, let's imagine that she is standardized patient acting with acute otitis media. That otoscope looks really quite threatening. And I look at the expressions on the students' faces, and the fear in the eyes of this child makes me uncomfortable. So I would like to offer a quote that, again by Iona Heath, from the same text, I think. And so she says, "Sadly, medicine and medical research have a strong bias towards seeing the body as object," which I think that previous illustration shows. That kid is not talking about her earache, she's being pointed to as an object, and has tended to marginalize the importance of subjective experience. The result is the missing person. So just because there's a patient in the classroom doesn't mean the person is participating in health professional education. And I think this presence should go far beyond the case-based learning and the standardized patient that is familiar in today's education. So what I'm talking about is equal voice, recognizing that there's a distinct patient experience, that the patient and the authority is the authority who carries out responsibility for the vast bulk of care. That's a 24-hour job 7 days a week, 360 days a year. And the patient may see the physician occasionally, but the patient's experience is the authority. In shared decision making, we base it on mutual respect and a commitment to care continuity. So this is the concept of care that we're moving towards. That I think that shared decision making is kind of an intermediate towards something like patient-led care, which is just over the hill and actually emerging in some areas. So there are obviously also new roles that this kind of power rebalancing has created in research and policy and governance, in setting professional standards and an accountability for the public, and accountability within the professions. So that's the world we need to be training for. I prepared this slide some years ago with a couple of colleagues when we were looking at what happens, postulating what happens when a clinician learner asks an open-ended question of a patient. So it could be a nurse, it could be a medical student who might ask a question like, how can I improve your care today? Or would you tell me why you're here in this clinic today? And then to listen carefully. So this is called a force field diagram, and on the left-hand side, the blue column is the driving forces that support that kind of behavior and the kind of benefits from just the act of asking a question and listening. And then on the right-hand side, some of the restraining, the inhibiting forces. So the top part is for persons and families that are being asked questions, and the bottom part is for those learners. So, for example, for a person to be asked, how can I improve your care today? Who I am matters, right? What I say matters. Somebody's actually listening to me. So that's self-confidence. And you can read these words yourself, and the slides will be made available. But you know, when a patient feels a greater level of self-confidence and perhaps trust, other information may come out that might otherwise not flow. So it is a step towards something even more productive, even more supportive of better care. But what I would also say is these kinds of experiences, the positive ones for the learners, for the medical students or for the nursing students or other health professionals, is the courage to ask open-ended questions and not be afraid of what the response might be. And to understand the core skill of, I can hear you. I know how to listen. I know how to hear what my patient is saying. And then depending on what kind of question it is, it can award agency and all sorts of other things. So there are some positive effects for the learners as well in developing the confidence and the skills. And I think that the seeds that are buried in those experiences on the left-hand side of this table are the kernel of reward. Why does a person go into health professions? And the rewards are to feel that satisfaction in actually helping someone, in actually hearing someone, in sharing their path, sharing their journey, sharing their experience with humility and with respect. Now on the right-hand side, in the sort of orangey color, are some of the restraining forces. And much of this is what's well documented in the so-called hidden curriculum. I can't do this. From a standpoint of the learners, this is unfamiliar. I don't have time. I don't have time to do this thing. I'm too junior. You know, somebody more important has to. I'm not confident that I can help. It's not my job. I'm here to learn. I'm not here to listen to the patient. And for the patient, there are all the inhibiting factors of the kind of medical practice I grew up in, when the best patient was the immediate patient. You didn't dare ask too many questions because you needed the health professional to not be annoyed with you. And we knew that annoyance was just over the edge of using up their time. So this, I think, this helps explain rewards for a way of teaching that is based on listening. How does that happen? Well, in scenes like these. So we learn the skills by listening to patients, by forming and strengthening trust for better care, for better communication, for better recovery, and a better sense of oneself, whether you're a patient or a health professional. And it's these relationships, as strengthened relationships, that can withstand the unexpected stuff that happens in healthcare. Embracing uncertainty, I think, is one of the core abilities that health professionals need to start to feel comfortable with. And to be able to convey to their patients, to the public, that medicine isn't plug and play. I grew up in the 1950s, and many of us felt that, and expect the silver bullet. When we walk into a doctor's office, we say, give me the prescription, fix this thing. Well, increasingly we have chronic conditions that don't have a thing to be fixed. There is no silver bullet. It's about self-managing old age and self-managing other kinds of chronic conditions that don't have cures. That grates against patient expectations, but those expectations were founded in an era of the 1950s when vaccines did cure. You know, when I was a child, there were kids in iron lungs, and I remember diphtheria, quarantine signs on neighbors' doors. In an instant, you know, I got the Salk vaccine for polio, a little sugar cube with a dot of juice on it, red juice, and you know, inoculations did cure deadly illnesses, and that's pretty rare now to see in old age anything that cures. Old age, we have the privilege of living long enough to have cancer and arthritis. I'm learning with an injured knee a few months ago. So developing relationships really is an insurance for the unexpected, and the unexpected will certainly come. And that helps protect the clinician as well as the patient. It also helps protect the team relationships. So this is where it happens. And the patient, imagine the patient is this kid with the yellow runners. The patient is never just this kid. The patient is, in fact, everyone sitting on the couch, because whatever happens to the kid in the yellow runners is going to affect everybody there. And things that affect other members of that family are going to affect the patient. So seeing the patient in context and understanding that the care plan actually has to address the whole social network surrounding the person, not just the one unwell person. And that means care choices and programs and monitoring outcomes and all the rest. So this is the world that our students are coming to. And this is a kind of yesterday and tomorrow set of changes. So relationship-based care, which is something that I'm glad I've got a name for, a label for, is this shift, this massive shift in roles, in reality, but also in philosophy and belief. Doctors making patients better is gradually changing into health game created in partnership. And simple or even complicated ways of dealing with medical problems are recognizing increasingly that problems are complex. That these are not readily understood. They emerge over time, and the solutions are more adaptive than plug and play, than interventions. We're moving from expert individuals into multidisciplinary teams, clearly. Some provinces more quickly than others, some trades more quickly than other professions. But it's a struggle. In British Columbia, we have political mandates now for team-based care and primary care, and it's going to be gradual. There's no question. And gaps will emerge that through which patients will fall. And crisis management is no longer the way to react to any health issues. It really is about the continuity. It's about continuing care to ensure that patients are safer and getting better quality care. Well, I think this is a familiar magazine cover to many of you. In May of 2013, the British Medical Journal had a wonderful, not only wonderful cover art, but also a wonderful editorial written by some of the mainstays in my life. And I want to read just a couple of short paragraphs, a couple of sentences, 3 sentences, I guess, on their proclamation, "Let the patient revolution begin." So here's the quote from the editorial. "The preservation of institutional bureaucracies, as well as professional and commercial vested interests, have consistently trumped the interests of patients. The healthcare industrial complex stands accused of losing its moral purpose. This corruption in the mission of healthcare requires urgent correction. And how better to do this than enlist the help of those whom the system is supposed to serve, patients. Far more than clinicians, patients understand the realities of their condition, the impact of disease and its treatment on their lives, and how services could be better designed to help them." So with that rallying cry, I look to the Canadian population. And I have had the privilege of traveling a fair bit, and the more I meet other people in other countries, the more I understand how incredibly fortunate we are to have a culture in Canada of, well, first of all, unbelievably, unrealistically patriotic support and optimism for healthcare. I know lots of people who have actually encountered care have different views, but there is a foundational allegiance that is similar to the NHS in the UK, although in the NHS there's much more active journalism that is all about big splashy headlines and inflammatory investigations and reporting that blows that sense of safety and confidence out of the water. In Canada, we don't have that. We have a much quieter journalism, much less journalism, and Canadians are really, really proud of our healthcare. Most Canadians think it's far more universal than it is, and I think the most recent PharmaCare campaign is wakening up a few people. What? My drugs aren't covered? For people who are well, there are many surprises on the road to becoming ill or looking after family members or others who are ill. So here's, in the popular mythology, Tommy Douglas is the most admired Canadian. And Canadians, furthermore, though, it's not all naive enthusiasm. What I think makes us so fortunate is that Canadians volunteer. Canadians know that our society depends on volunteers, and they're willing, actively willing, to participate in improvement. And that is not true around the world. There are many countries that have wonderful healthcare systems, universal systems, so-called, single-payer systems or widely subscribed systems, where the population feels, I pay my taxes, there's somebody employed to do that. What do you need a volunteer for? And we have something different here. So we have something that I call the citizen patient, and I've explained a little bit about my concept, that it's a person who steps forward with a perspective of the patient and who is acting in an altruistic way. It's not to help my own care, it's not about my own treatment, to improve my own, to benefit myself. It is about the other people. It is about other areas of healthcare. And Canadians hold a passion for this. I think it's important to respect that, or you lose it. So I have a few pictures of what this looks like in British Columbia, volunteering in a lot of different roles. And this is a photograph of one of our oldest health professional training programs with patients, and that's the Interprofessional Health Mentors program. Which pairs up a group of 4 usually. I don't know where the 4th person is, but there's usually 4 health professionals who are from different groups, different training programs, with someone with a chronic condition, and it's a year and a half long relationship that does have a structure of teaching. So the health mentor is a teacher in this. We have other examples of learning from patients, and this is a lovely picture of the ideal, where a patient who has experienced a stroke is explaining what his ideal is for connected care, all the different actors in his world. Now, nobody but a patient can do that. Nobody else can draw that. You could shadow this guy and not see those relationships. So this kind of lived complexity is something that patients can bring into health professional education. And I'd like to read just a couple of quotes about the justification, the evidence for the patient role. This is from Angela 10 years ago, Angela Toll. The literature provides evidence that learning from patients plays a role in the development of clinical reasoning, communication skills, professional attitudes, empathetic understanding, and an individualized approach to the patient. It also motivates students by providing relevance and context. And then in a more recent document that I'll show you in a minute, benefits to patients involved in education include satisfaction and giving back to the community, having an influence on the education of future professionals, and an increased self-esteem and empowerment. And I think unless you look at those inhibiting and behavior-promoting forces, you're going to fail in whatever initiative you have. You have to meet people's expectations and satisfy their motivations for successful collaboration with volunteers, with patients. So here's another picture from the Health Mentors Program, and this kind of interprofessional work over 9 months with a person who is identified as an instructor really puts meaning behind the language that we use of in chronic disease, chronic illness experience. So what does it really mean to have patience or courage, persistence, judgmental reception? You know, how are you judged by others? What about access to care? What's the real meaning of that? What does independence mean? And so the lessons in developing a good training program in relationship-based care is moving from crisis medicine to slow medicine. This is some of the language that's getting greater currency. You're not treating anyone, you're treating someone. So that idea of the individual. You know, guidelines are not made for individuals. Guidelines are handrails to maybe open and contribute to the discussion, but they're not regulations. Clinical histories become exercises in narrative humility. Instead, it is about listening and understanding. Instead of fighting for power, it's working with power. It's creating power, actually. And education becomes co-learning because it is a two-way exchange of information. So these are the kinds of lessons that we know are at the heart of relationship-based care. This is a poster from 2005 at Ubc. And Angela Toll and her group sponsored with chess, and I think, oh, maybe it was before chess was invented. Oh, it was about the same time chess was created. Anyway, it was where's the patient's voice in health professional education? I am delighted to say that this is before my time. I came into the picture in 2008, but 10 years later, where's the patient's voice in health professional education 10 years on? There were no conferences in between the two. So in 2015, there was a call out, about 300 people turned up from a whole lot of different countries, and there's some very good write-ups that are online on what transpired during that wonderful conference. It opened my eyes on health professional education, from all over the world, people who were doing far more than what I knew about. And so within a year, a group of people, as a result of that conference, created the Vancouver Statement. And, you know, as I say, you can get the citation from the slides later. But it does really, it presents a little bit about the past, some of the challenges of today, and then really a call to action. And one part of that work was to create a good example of the spectrum of involvement. And this is different from the International Association for Public Consultation, something like that. This is much more focused on health professional education. So there are different ways, different spectrum, ways along the spectrum of involving patients in training health professionals. And I won't read words from here to you, but there are good examples here of things that I do. And I can find myself here in equal voice on the admissions committee to decide who qualifies to get into medical school at the University of British Columbia, Canada's largest medical school. We have 288 students in our intake class. Half of those turn out to be family practitioners. And there I am voting with equal voice, and I'm not the only patient on that committee, on who is deemed admissible. And there are many other examples. You know, I have been over the last year the theme co-lead for patient safety for the undergraduate medical program. Wow, I sit on the curriculum committee for patient safety in the graduate medical program. And Rob, you'll be interested in bringing it into the 21st century, I hope. And there are many other examples of ways in which patients at UBC are filling roles that they may not be revolutionary, but it's important to look at opportunities. I'm going to show a couple of screenshots from the website for the Angela Toll Group, the Patient and Community Partnership in Education. And so this is, you know, one report that's reporting on a couple of projects that are ways of learning, experiential learning from patients. The health advocacy training for health professionals are giving examples. And in fact, there's a mini course and all the materials there to do it yourself, to run the course yourself, on how to succeed in training for that PenMeds skill, capacity of advocacy. And then there are a couple of videos to show you the results. The Patient and Community Voices Workshop series is ways of bringing patients into the classroom as teachers and leading workshops with health professionals. Some of the health professionals are from single professions, other times it's interprofessional. The Living Library is a series of videos with patients talking about living with Alzheimer's, living with epilepsy, and encounters that have been important for them and traits of that experience that are important for them. So those videoed resources are available. And the Community as Teacher Cultural Camps is an example of working with Indigenous communities in the Lower Mainland to learn with those communities. So it's not teaching at health professional students, but inviting the students to come to a camp that's actually designed for cultural orientation for young people within the community, and the health professional students are invited in to learn alongside everyone else. And then finally, there's important initiatives in partnership, collaboration. So I want to talk about all three of these different examples of partnership initiatives. So there's Meeting of Experts, the Patient Advisory Committee, and Patients in Education, or PI. And the Meeting of Experts is actually the public-facing website that the Patient and Community Partnership for Education has that documents a lot of the programs that they have, and the website address here is in blue, not white, as it should be. I apologize for that, but I'll provide a set of resources for you to follow, a set of references. And this is a new website and fabulous. It has as one of its screenshots this image, and it really is inviting patients, students, faculty, and community to get in touch and to get involved through this public-facing portal, this outer-facing portal. So the next slide is a little bit daunting, but that's because healthcare is complicated, and university structures, organizational structures are even more complicated. But what I've done here is try to give you a notion of what UBC Health is. And UBC Health is across different faculties, providing an umbrella organization that draws on all the different departments that contain health professional education. So you can see there's medicine, obviously, and nursing that's in applied sciences, dentistry, clearly, pharmaceutical sciences, land and food systems for dietetics, in the arts, social work is involved, kinesiology under education, and for health and social development, there's also parts of nursing and social work, health and exercise sciences. So, and there is talk about involving some other faculties. So the umbrella organization here is a bit of flux. This has traditionally been what it is. We now have a new vice president of the university who is our Dean of Medicine for the time being. It could be anyone else from UBC Health. But that vice president portfolio is going to create 3 new directors, a director of health education, a director of health research, and a director of health systems. And I think the call is still out to staff those positions. I don't think the deadline's passed yet. So the Office of UBC Health that overlooks the council, the UBC Health Council. I'm a member of the UBC Health Council. There is another public member of the UBC Health Council. The Health Council has a patient advisory committee, and it's a fairly large committee. I think there are 8 or 10 members. I should have looked that up before the talk today, but those patient advisors are independent. You know, they have a strong voice, and so they advise UBC Health on all sorts of policy, all sorts of important issues. Now, there's a red dotted line there because outside of UBC is an organization that I was a founder of, a co-founder of, Patients in Education. And the reason we invented such a thing is that we know that having different methodologies to connect with different parts of the community for involvement at UBC is a complex exercise, and that very oftentimes non-academics are the best liaison into community. So based on a foundation of Health Mentors program and other UBC programs, which is the bottom block, the bottom strata of pictures here, all the different people who are involved in these programs, came the middle stripe, which was a forum talking about what could a role be for a nonprofit society in assisting not only UBC but other institutions that train health professionals to join up with community groups, particularly, not so much individuals, but through community groups, whether they're cultural or interest groups, whatever, but those groups would be interested in affecting health professional education. So on the top, those are the founding directors with her beautiful certificate from the provincial government as we founded Patients in Education, or PI. So that was a couple of 3 years ago, and since then we have put on a number of fairs. We've had forums to discuss issues and structure, and because we're all already overcommitted volunteers, progress is a bit slow, but we have a website, and we believe that our role is in strengthening diversity, strengthening the ability of health professional trainers to access a much more diverse group of participants in the classroom. And this is what our website looks like. It's a brand new website. It needs to be brought up to date a little bit, but we're facing the opportunity to help patients, to help students, and help educators, and to act as a kind of matchmaker. There was a report a couple of years ago that I showed as my opening slide that I said I could just walk away and you could look at it. The 2018 report on the role of patients in health professional education at UBC, and it documents that one of the biggest barriers is simply time. Instructors don't have the time to figure out how to recruit patients that they want to help co-teach, to help participate, to help design their instruction for health professionals. So to lower that barrier, PI invented, and we work very closely with PCPE. And really what we're looking at is exploring the connections with neighbors and with family and with friends, colleagues, cultural leaders in all the ways in which those relationships define care. We want to learn what makes these relationships better informed, more resilient, more satisfying. And the future really is in relationship-based care. So we might say that it takes a village to train a health professional, and we want to be able to really facilitate forming that village. So we think it's just the highest importance to recognize connections amongst each other in health professional education. Now I want to just leave, and I know we've got just a few minutes left. I wanted to just tell you about another research project that I'm involved with that is a great illustration of the kind of collaboration that's going on at UBC. So Cheryl Holmes is Associate Dean of the Undergraduate Medical Program, that's her responsibility. And Bav Chima is a second-year medical student. And during her flex period, where it's an independent project, dedicated time, she decided she wanted to look at addressing the so-called hidden curriculum in residence. And she worked with Cheryl and a handful of other people, and their names are on this slide, to develop a project that has gone through its phase one. We now have funding for further work from the Royal College. UBC Chess is a part of this. Cheryl's I think a senior scholar is, I think that's her label. And I've been a groupie with Chess for a number of years, and we have other members of Chess who are involved in on the project team, as well as professional development and internal medicine and others. So what we're doing is we're looking at how to shift from the learning dyad in residency of the attending physician and the resident to a learning triad. That is to have all of the teaching done with the patient present. So it's not about the resident collecting the medical history and then going off into a conference room and presenting that to the attending. Instead, it's done in front of the patient. And the patient has an opportunity to say, oh no, you forgot about, or no, that's not quite right. Or to sit back and we've been doing these interventions, doing interviews, and documenting the themes that arise from the interviews. And what we find is patients are saying things like, it's so wonderful to see that they actually are dealing with me, and that I see before me the transfer of my information from the resident to the attending. And the attending is really listening. It doesn't bother me that I don't understand all of the vocabulary. The instructors, the attendings are sometimes saying, I have to change the way I present my lessons. There are some things that are a bit sensitive, so this might not work in every case. We're doing it in a internal medicine outpatient setting for now, and our next phase we're gonna expand it a bit. But so far, the students are finding it challenging, the attendings are finding it challenging. Of course, the students don't want to look stupid, and the attendings don't want the students to feel as though they're being embarrassed. isn't that what the hidden curriculum issue is all about? So it's very interesting. It's a fascinating project. And stay tuned. We'll see how we go in the next phases. And I have to say that Bev Chima is a superstar. Watch that girl. So I would like to keep talking with you for a few minutes. There may be some questions from online that have come in. If you would like to talk beyond now, I'm more than happy to receive your email and get together otherwise. So if you have some questions or comments or challenges for me, I welcome them right now. Thanks very much for your attention. Yes.
I'm Bernice King, and I'm a patient advisor at St. Joseph's Hospital.
Great.
So I love what you're talking about. Have you gone one step further after they graduate? Does it make a difference in the quality of care that these students or people provide, or why I'm being the other side of the board, like why would I go to all this trouble if it's not going to make a difference? And that's probably very hard to research.
So that it's an interesting question, because I think since I first peeked behind the curtain in healthcare, I started asking, where's the accountability? And I have that instinct always in me, the so what, right? And I think that as, for example, this project that we've just been working on, there's a lot of so what that happens immediately. One of the most, we hear the students, the learners saying, this is challenging, but this is what I want to do. This is the way I want it to be. And so the positive feedback from just we barely started that project. The Health Mentors program that's been around forever generated one of the most moving experiences I've had in listening to students. It is the most moving experience I've had listening to health professional students. At the beginning of that conference in 2015, there were 3 young people who were at various points in their medical career who commented on their experience from Health Mentors. Now, in occupational therapy, it's required that the students participate in the Health Mentors program. In medicine, it's not required, it's an elective. And those interprofessional teams of students can't have duplicates. They have to have different professions represented. And each of those young people said things about the way in which that experience over 16 months, the program was then, how that had transformed and inspired their practice, their attitude, their culture. They couldn't imagine what their work ahead would be like without it. Now, when you hear that, you say, yeah, but so what happens when you're 10 years on the job and in the burnout treadmill? Those young people have a commitment to leadership that is the only way change happens. I came in the door of healthcare through tragedy. My husband died for all the wrong reasons 8 days after successful surgery. And, the surgery was a success, so what could happen? And the lack of leadership and the lack of accountability through that was something that really shocked me, really astounded me. And I've been thinking over the last decade of how could I contribute to positive change? And I think the work that I do with medical students is and nursing students and other interprofessional students is the most important thing I could do. I think it's very difficult to change culture, but it is possible to create leaders and to create strong enough bonds among health professional young people, young practitioners, that they act as teams. So they're not sticking out like a lightning rod, waiting to get struck, that they have the skills to avoid the lightning strike, but also to build a movement, to build change in the clinical practice areas that they find themselves in. And if we have enough young people who realize that's how change happens, and that those are the levers that they have to change the way the public, the patients want medicine to be practiced, and the conditions in which they want to practice medicine, then we will experience change. But so I'm passionate about the work that I do with young people, because I think they come into training so optimistic, so strongly attached to the patient experience, and by Christmas, whoa, it can be beaten out of them. So I'm also on curriculum reform committees, trying to poke where I can. But without cultivating that passion and that leadership among the students, I think we're scuppered.
I was interested in your use frequently of the paradigm relationship-centered care, because when this was first written about Tony Suckman and Tommy Newey in Indiana like 20 years ago, they were basically, it was a movement almost against patient-centered care, which, looking at a family doctor, had been the paradigm of care, particularly in family medicine. But in relationship-centered care, the point that Tony Suckman was making is it's a relationship, and therefore the healthcare provider, physician, nurse, physio, whoever, is in a partnership and a relationship with the patient. And now bringing the patients into education, I'm just sitting here wondering about looking at how you've alluded to it, how our learners feel in this relationship, studying how, as they begin to interact with the patients, particularly with other healthcare professionals in the IPE setting.
That's right.
Studying, what are they feeling? Is an effective component to it.
Absolutely it is.
Not just the education about the patient's medical trajectory.
No, that's exactly right. That's exactly right. And the health mentors are incredibly generous. And it is about building that mutual respect, but also mutual vulnerability. It's magic, and it is exactly what you say. Patient-centered care has bothered me since the first sort of schematics that I saw with this poor patient in the middle, isolated by these other silos of specialists. And wait a minute, it's all about the connecting lines. It's not about, some of the more progressive drawings that I've seen since those days have care in the middle. So how do we all participate in care? But that doesn't quite capture it. And I think the literature, as you cite, around relationship-based care is robust, and the students love it. They find meaning in the slog of learning, and inspiration, as I say, for courage to be leaders.
Thank you so much, Carolyn, for making the trip from Japan, actually.
Well, they are crafted.
I think that some of the work that you're doing at UBC is really on the cutting edge of this, and we're so lucky to learn from what's going on there and think about how we might implement that in the health professions education programs that we have here.
Great. Well, I will leave you with references so you can follow up with what's online, and encourage you to correspond with the patient and community partnership in education, and there's a tremendous amount of. I don't think that we're necessarily light years beyond what's going on other places. The more I'm around healthcare, the more I realize that there are spots of excellence that nobody knows about. Right? And we would find, if we look closely enough, that there are places in McMaster that you don't know about where magic is happening, where absolutely phenomenal innovation is happening. And it's just really hard to connect. So the more we talk about it, the more we can help each other out by introducing that cross-fertilization. Thank you, Meredith.
Thank you.
And thanks everyone for listening.